Good evening, everyone. Today we are having in our neurosciences forum. We are starting the program straight. Now I invite Dr. Sitharaman, the Secretary of IMA Coimbatore, to give the welcome address. So now, the Neurosciences Forum is a program which we are conducting every month continuously for past almost 1 year, more than 1 year. And in this, the main interesting thing is we will be having one neuromedical topic and neurosurgical topic. That is the main difference in these sessions. Because in all the meetings, the neurophysicians forum is separate and neurosurgeons forum is separate. They are not mingling. But NSC is the only forum where both are available and both will be presenting their presentations. So I invite you all for this nice program. You must be wondering why the brain death and certification is added in this month. It is because in this month only we are celebrating the National Organ Donation Day and also the International World Organ Donation Day. That's why I thought it will be of use to the people, because a lot of things are happening in the organ donation day to day. And even while telling about the organ donation, I wanted to tell that recently one of the pediatricians in Chengalpattu Medical College has recently died of road traffic accidents because of the failure of one of the government buses. There is a collision between one private bus and one government bus, and accidentally the pediatrician who was walking by the side of the road suddenly had the injury and he died on the spot. He is a pediatrician. But what is the pathetic situation is that last week only he has done the registration for the organ donation pledge, and he has issued the certificate. He put up all the certificate in this WhatsApp group. That's what he has done. So I wanted to inform that in this forum. That much people are more aware about the organ donation now. So we should be spreading message more about the organ donation. And now we will have the first speaker. The topic is Central Nervous System Demyelinating Disorders, Differential Diagnosis and Approaches to Management. This seems to be a different topic because it's rare to see a topic like this, because demyelinating disorders people are having, and then it's very difficult. People are coming with a lot of pain and all those things. So to give an education about that, that's why we have included the topic. And today's speaker will be one of the senior consultant neurophysicians from Coimbatore, Dr. K.K. Prachit, who is a senior consultant neurophysician at the Ganga Hospital, Coimbatore. Dr. Prachit Kulkarni Krishnamurthy is done his MBBS from JIPMER Pondicherry 1992 and MD General Medicine from JIPMER Pondicherry 1997 and DM and Neurology from the NIMHANS August 2000. The position held the consultant in neurophysician Lotus Apollo Hospital E Road and Bolineni Super Specialty Hospital in Nellore, Andhra Pradesh, and at Coimbatore as a consultant neurologist, worked at KG Hospital, GKN Hospitals. Worked at NMC Royal Hospital, Mumbai, Dubai, as a senior consultant neurologist from April 2018 to September 2025. He has done a lot of presentations in the national and international forums. I welcome Dr. Pratit sir to give his talk. Welcome you, sir.
Thank you very much, Dr. Rajesh Babu, for your kind words, and your enthusiasm is always something to be followed upon. One of the most enthusiastic persons I've ever met. I've never seen him in a dull moment. Thank you once again. So let us start off. And today's topic is on demyelination. The reason I chose this topic is because, just a minute.
Share the screen, sir.
I chose this topic is because many of us, including myself, had a very vague idea about demyelination. It also means that demyelination is equal to multiple sclerosis. It cannot be treated. Things have changed significantly in the last few years, especially last 10 years. Treatment is totally different, and it's important to know and approaches. So what are the differentials? Differentials are acute disseminated encephalomyelitis, multiple sclerosis, Neuromyelitis Optica, myelin oligodendrocyte glycoprotein antibody associated disease, commonly known as MOGAD. Neuromyelitis Optica is known as NMO, and others being PML, osmotic demyelination, radiation induced, etc. So we will not deal with others. Our focus is on the first four. So the approach is, so basically we'll have to find out which are the areas of the brain which are involved. Is it the brain which is involved? Is it the spinal cord which is involved? Is it the eye which is involved? Is it involved alone or in various combinations? Usually they are acute, but not necessarily so. Other diseases can mimic, for example, sarcoidosis, IgG4 diseases. These can mimic demyelination, and we have to be watchful for this. I will show you some examples down the lane. So let's start with ADEM, and some points to know. So ADEM is a very, it's generally an acute symptom. Very severe cranial nerve symptoms may be there, obtundation, focal deficits, rarely seizures, paraplegia, and quadriparesis. This is the usual. Just a minute. Yeah. Sorry. Can you see the presentation? Yeah. Is it visible now?
Yes, sir.
Okay. So, okay, sorry about that. Okay, next. So generally ADEM is, it's a very severe symptom usually. They have cranial nerve symptom, obtundation, rarely seizures, and paraparesis and quadriparesis. In neuromyelitis optica or NMO, there will be optic neuritis, intractable vomiting. This is a point to be remembered. Patient can present with intractable vomiting. Just now admitted one patient with intractable vomiting and hiccups. They can present with drowsiness, spinal cord symptoms, long segment, and quadriplegia, paraplegia, etc. Next is the MOG, where you have optic neuritis, spinal cord involvement, brainstem symptoms, fever, and seizure. So it is to be remembered that MOG can present like a infectious etiology. And last is multiple sclerosis, where the classical description is a relapsing remitting disease with optic neuritis, spinal cord involvement, and gait involvement. So let's go one by one. So first is ADEM. So the pathology is immune system dysregulation. It is usually triggered by infectious agent, and it is an autoimmune etiology is proposed. Epstein-Barr virus may trigger the autoimmunity. Histologically, they are different from multiple sclerosis. The incidence is 0.2 to 0.5. In children, it is fairly common, and most are post-infectious. So there is usually a viral febrile illness preceding the onset. It occurs in 75%. 4 to 14 days after infection or vaccination. Fever, headache, vomiting, and meningitis are usual accompanying symptoms. Encephalopathy, it can range to encephalopathy, drowsiness, meaning that patient can come with fever, headache, vomiting. Within 2 days, they may go into deep coma. Early deterioration can happen over 7 days. They can have pyramidal signs, ataxia, cranial neuropathy, optic neuritis, and myelopathy. The severe phase usually lasts 2 to 4 weeks. Sometimes there can be hemorrhage known as acute hemorrhagic leukoencephalopathy. Prognosis is bad, rapidly progressive. Evaluation is usually by MRI brain and spine, lumbar puncture, and testing for MOG antibodies. So you must remember that lumbar puncture is not a necessity. Suppose the spinal cord is involved and there is significant swelling, then there should no need to do lumbar puncture. In fact, it may be a contraindication also. Lesions are usually bilateral, but they are asymmetric and poorly demarcated and hyperintense on T2. So what are the diagnostic criteria? So it has to be polyclonal, focal or, focal, it's a mistake, sorry, it's not first, it is focal or polyfocal, CNS, inflammatory demyelinating event, encephalopathy that cannot be explained by fever. And it is important to know that no new clinical and MRI findings emerge 3 months after onset. Brain MRI is abnormal during the acute phase. Diffuse, poorly demarcated lesions in deep white matter. Deep gray matter lesions are also known. And absence of T1 hypointense lesion. This differentiates it from multiple sclerosis. Treatment is usually methylprednisolone, 1 gram intravenous, 3 to 5 days, followed by oral. In very severe cases, concomitant plasmapheresis or IVIG is advised, especially if response is not adequate. Supportive measures, ventilation, physiotherapy. And it has to be remembered that MOG antibody is associated in nearly 1/3 of the patients, and it has to be looked for because treatment duration, everything varies. Now next, let us come to, just a minute, sorry about this. Yeah, let us come to multiple sclerosis. See, this is by no means a complete, this is just a rough idea so that you will get an idea. Our main idea is the intention is for you to get the overall picture, and so that you will be able to segregate these patients into different types instead of vaguely telling them as demyelination. So dissemination in space and time, this is the most important aspect of multiple sclerosis. That means it occurs at different intervals in different places in the white matter. Age group is usually 15 to 45. Females are more affected than males. It is very common in northern hemisphere, cold climate. One reason proposed is lack of vitamin D. However, it is extremely common in Middle East. So the reason is not known. Epstein-Barr virus is one of the proposed etiology. Another thing is fact is that even though it's extremely hot in the Middle East, people are literally they go from AC to AC. They are at AC at home and at workplace they are in AC. Car is AC. So literally they don't go out. So pathology is usually T cell and B cell mediated, predominantly T. So this is important. What are the sites of involvement? Sites of involvement are 1, optic nerve, 2, brain periventricular area, 3, brain juxtacortical area, 4, brain infratemporal area, and 5 is the spinal cord. I will show you some pictures. So this is the criteria. Okay. So if you see, so the main thing is if there are 2 clinical attacks and objective evidence of 2 lesions, so you really don't need any other data to diagnose. Okay. Suppose there are 2 clinical attacks and objective evidence of only one lesion. That means there is dissemination in time, but there is no dissemination in space. So you need another attack to make a diagnosis of multiple sclerosis, or you need an MRI to show that another area is involved which is not there clinically. Another scenario could be one clinical attack and objective clinical evidence of two lesions. So here you have two areas which are involved, but you don't have, but you don't have, what to say, two time place you don't have. So you have two areas, but only one attack. So here you need to prove that one more attack has happened in the past. So how do you do that? Either you do a CSF oligoclonal band, or you should do a contrast MRI showing simultaneously non-enhancing lesion as well as enhancing lesion. Okay, and the last one, oh sorry. Yeah, then the last one, there is only one attack and clinical evidence of only one area. So here you need to do both. That means you need to demonstrate one more attack and you need to demonstrate one more area. See, this is the standard McDonald criteria. However, now there has been a recent modification. So I don't want to confuse all of you with this. So regarding area, they've included a fifth area, which is the optic now. So that will keep it in mind. We'll move on. So basically, it's a relapsing and remitting disease. It can be either primary progressive or secondary. That meaning thereby that sometimes normally it is a relapsing remitting like this. Sometimes what will happen, it can just progress like this, or it can relapse, remit, and then after that it can progress. So when the optic nerve is involved, it is usually unilateral. Visual prognosis is good in optic neuritis. The reason you will know subsequently. Response to steroid is good. So spinal cord involvement is usually incomplete. So points to be remembered is that visual prognosis is good. Spinal cord involvement is incomplete. That means they'll have weakness, but they'll be able to walk. There are some typical MRI findings. So you'll have T1 iso to hypo in the calloso-septal interface, T2 hyperintense, so in the flare, DOS and fingers. SWI, there is something called central vein sign. Active lesions will show enhancement. Spinal cord lesions are usually short.
Slide not changed.
So it is important to make a correct diagnosis because treatment options are excellent at present. However, a careful assessment of age, sex, marital status, family support, financial viability needs to be done. It's a shared decision making. That means one has to sit with the patient and family and then decide. Now, initially it was a step-up approach, meaning mild used to give milder drug, severe used to give severe drug. Now it's the other way around. Now it is top-down approach. So when this interferon is a mild drug, next is dimethyl fumarate, then is CD20 inhibitors like rituximab, then very effective is natalizumab. So hit hard at the onset, that's the concept. So how do these medicines work? So interferon, suppression of cytokines, dimethyl fumarate increases humoral anti-inflammation, fingolimod blocks the lymphocytes, rituximab, ocrelizumab, ofatumumab, anti-CD20, natalizumab blocks T lymphocyte migration, cladribine lymphocyte, and alemtuzumab binds to CD52 antigen. As I said earlier, interferon is a low efficacy, but it's very, very useful in pregnancy. So in pregnancy, interferon can be, it's the only drug which is approved. They can have flu-like symptoms and pain, which can be very disabling. Next is dimethyl fumarate. It's an oral, intermediate effective. It has a lot of GI side effects. Next is fingolimod, oral, intermediate, but there is cardiac toxicity, so cardiac monitoring is essential. Then anti-CD20, these are high efficacy. These people are very much prone for severe varicella infection. So we'll have to vaccinate them against varicella if they have not been affected by chickenpox, and then only give. Cladribine is an oral high efficacy infection. It is very, very expensive, but the advantage is only 2 years treatment. That is, you give one course, 5 tablets for 1 year, and then again after 52 weeks, 5 weeks, that's all. But it's extremely expensive. See, the average cost of multiple sclerosis treatment per month in the West would be somewhere around, it'll be somewhere around 2.2 lakhs or so. So which means the patient has to take every month this medicine for a long time. And cladribine, you can imagine it will be at least some 15-20 lakhs or so. So cost is a big problem. But one of the most effective drugs, especially in high patients with high lesion load, is natalizumab. Very high efficacy, but the problem is PML, that is, they can have JC virus infection, and progressive multifocal leukoencephalopathy is common if it is given for more than 2 years, and they have to be monitored by JC virus antibody. And prior immunosuppression predisposes these people for PML infection. So it is very important to monitor these things. Alemtuzumab has got the highest efficacy. This is a reserved drug. Only in the end, when nothing works, we'll have to give this. So certain things is that though it is relapsing and remitting, it is actually a progressive disease. So start early and hit hard. Long duration of treatment not to be stopped. Can step down to lower efficacy drugs subsequently. Pregnancy has to be planned. Acute episodes have to be treated with steroids. Monitored by serial non-contrast MRI once in 6 months to 1 year. Vitamin D supplementation is very essential, and vaccination. Nowadays, Epstein-Barr virus vaccine has been approved for multiple sclerosis. So the take-home message on multiple sclerosis is prognosis excellent if treatment is started early. Now there are some other scenarios. It's something called radiologically isolated syndrome, where you have only clinical features of radiological features of multiple sclerosis, but there is no symptoms. Such patients need not be treated. And however, patients with a very high lesion load, male sex, and cervical cord involvement, some people do treat. Next is clinically isolated syndrome, where you have single episode but multiple sites of involvement. And here if CSF OCB is positive, it is to be regarded as multiple sclerosis. And multiple sclerosis and pregnancy to be planned, interferon is the treatment of choice. In progressive multiple sclerosis, ocrelizumab is the treatment of choice, and that's the only drug approved. And nowadays, a lot of pediatric patients are coming with multiple sclerosis. The lesions are bigger and they're atypical. Fewer drugs have been approved. Now, after finishing this, I'll show you some case scenarios so that you will understand. Next is Neuromyelitis Optica. This is a disease-specific NMO immunoglobulin antibody was found, and which selectively binds to aquaporin AQP4. This antigen is a water channel protein found abundantly in the astrocyte food processes at the blood-brain barrier, mainly in the spinal cord, periaqueductal regions, and periventricular regions. It's an autoimmune pathology. It's an astrocytopathy, and associated autoimmune diseases and ANA positivity is fairly common. So NMO, it is sporadic. It is more common in Japan and Asia. The areas of involvement are optic neuritis, area posterima, that is the dorsal medulla. This is where the patients present with intractable vomiting. They can also involve the brainstem and cerebrum. See, of the three, this is the worst prognosis. So it is very important to recognize them early and treat them early. Optic neuritis, visual loss is associated with eye pain and worsens with eye movements. And optic neuritis can involve both eyes, either unilateral and can be sequential or together. They can also present with transverse myelitis. It can be symmetric para or quadriparesis with bladder dysfunction and sensory level below the findings below the level. Longitudinally extensive transverse myelitis. This term we should all remember, LETM, that is 3 or more vertebral segments on MRI. So when you get LETM, think of NMO and even MOG, but MS usually it is short segment. Area posterima syndrome or dorsal medulla with nausea and vomiting. Hypothalamic lesions can cause narcolepsy, hypotension, and hypothermia. The other important things are hyponatremia, muscle involvement. Pain is fairly frequent. 75 to 80% will complain of severe pain. They usually respond well to carbamazepine. The relapsing course 90%. The difference is between MS and this one is that MS usually if treated early, the relapses usually they do recover almost completely, whereas here almost always they have residual deficit. Secondary progressive phase is very rare, unlike in MS. Optic neuritis that is simultaneously bilateral involving optic asthma causing severe residual visual loss despite steroid treatment, think of NMO. Complete spinal cord syndrome with paroxysmal tonic spasm, think of NMO. Area posterima syndrome, think of NMO. It is important to take blood for antibody before treatment because if you start steroids and then take antibody, it will become negative. Then it becomes very, very difficult. You don't know what you are treating. And early treatment is crucial. So there are some red flags. A progressive course goes against NMO. Time to peak less than 4 hours. That means patient starts with some peaks of paraparesis and the peak deficit is within 4 hours. Then think of the vascular etiology. Partial transverse myelitis is very unusual. Comorbidities, if there is any sarcoid or cancer, HIV, again think of other reasons. Imaging, involvement of Dawson's finger, U fiber involvement, cortical lesion, periventricular lesion in the inferior temporal lobe, short segment lesion in the spinal cord, peripheral lesions in the spinal cord. These are all red flags for NMO. Now, as in MS, there are some criteria. So, there's no need to memorize, it's all readily available. So, at least one core clinical feature should be there. I will come to what is core clinical feature. Positive test for aquaporin antibody, exclusion of alternative diagnosis. So you can still make a diagnosis of NMO without antibody being positive when you should have two core clinical features. At least one of them should be major, that is optic neuritis, acute myelitis with LETM or area posterima syndrome. There should be dissemination in space and MRI should be suggestive of NMO and exclusion of alternative diagnosis. So what are the core features? Optic neuritis, acute myelitis, and area posterima syndrome, these are the core. So if NMO is negative, two of them should be there. Less common are brainstem syndrome, symptomatic narcolepsy, and symptomatic cerebral syndrome. Supporting MRI requirements are, you see here, the optic nerve involvement will be more than 50%. This early TM will be more than 3 segments, and area posterima syndrome, dorsal medulla will be involved. Periependymal lesions are very, very typical. So this is the same thing. Yeah, I told you, large confluent subcortical deep white matter, dorsal medulla involvement of the optic chiasma or posterior half, and cord swelling. Okay. Now, this antibody testing is very crucial. The correct method, which is very, very important, it's rarely associated with MOG antibody. It is very specific, false positive, very rare. Serial monitoring, not useful. With a combination of clinical, radiological, and laboratory features, it is easy to distinguish MS, NMO, and MOG. Okay, now treatment comes to, there are two things. One is treatment of attacks, and then another is to prevent attack. Treatment of attack, IV methylprednisolone 1 gram for 5 days. Response usually suboptimal, and many benefit with second therapy or many times adjunct plasma exchange. For example, a patient comes with severe optic neuritis, not able to see anything, or extensive spinal cord involvement. We'll have to add plasma exchange. Maintenance therapy is important with rituximab, azathioprine, or mycophenolate. There are other drugs, eculizumab, satralizumab, etc. So some things are mortality due to respiratory failure, and natalizumab and fingolimod are to be avoided. Prognostic markers are very severe disease at onset, multiple relapses within first 2 years. Next is MOG. This is the last one, after which I'll show you some short clippings. MOG or myelin oligodendrocyte glycoprotein associated disease. It's a minor component of myelin. It's common in children. Unilateral or bilateral optic neuritis resulting in severe visual loss. They can have ADEM. It is usually monophasic in 30%. They can have transverse myelitis. Sometimes attacks can develop over weeks. It is often preceded by fever. This is the most common presentation. It is associated with eye pain. So the point to be remembered is optic disc edema is found in 86% with peripapillary hemorrhages mistaken for raised ICT. It is bilateral in 50%. Recovery is typically good. That's the difference. They respond very well to steroids, unlike NMO. Spinal cord involvement may be isolated or with other features. Bladder is involved. Erectile dysfunction is common because it has a tendency to involve the conus. Again, long segment or longitudinally elongated transverse myelitis. Yeah, as I said, it is ADEM, think of MOG, and MOG can present like ADEM. Sometimes they can be cerebral monofocal or polyfocal due to lesions in the MCP. Ataxia, diplopia, brainstem cerebellar features. Isolated brainstem features are more common in MS. This is one thing we should know. This is cerebral cortical encephalitis. That can, they can present just like a seizure, aphasia, stroke. They are associated with leptomeningeal enhancement. This is called flare-associated lesion in anti-MOG associated encephalitis with seizures called flames. Optic neuritis, when to suspect MOG? Optic neuritis that is simultaneously bilateral involving anterior pathway, ADEM-like presentation, unilateral cortical encephalitis, and MOG antibody is required for diagnosis. Again, in spinal cord, onset to peak time will be less than 6 hours. It's a problem, red flag. Progression beyond 1 month is a red flag. Presence of oligoclonal band is a red flag. Absence of enhancement of optic nerve is a red flag. T1 hypointense lesion is a red flag. So, Investigation is MRI of orbit, brain and spinal cord, serum MOG. CSF is optional. Enhancement of optic nerve is typical in the anterior portion. So, in spinal cord, you may get head-shaped lesion in the central gray matter. So, another important test is optic OCT, that is optic coherence tomogram. Here you will find that in MOG, the thickness of the RNFL, that is retinal nerve fiber layer, will be very thick, unlike in optic neuritis due to multiple sclerosis or NMO. That is another way which we can differentiate. So again, cell-based assay is very important, and titer is very important. It should be more than 1 in 100. Low titers, false positive is fairly common, and testing has to be done before starting immunotherapy. So now treatment is again methylprednisolone, 50% they resolve on their own. Rarely you like to give plasma exchange, tocilizumab. Okay, now we'll do case scenarios and we'll wrap up. This is a 24-year-old girl presented with recurrent episode of numbness and weakness of limbs, paraparesis, hemiparesis with visual blurring. She had a high lesion load and it used to recover every time, and she had a high lesion load and she was on high efficacy medicine. So there is classic example of dissemination in space and time. Young patient with a high lesion load, it is important to continue high efficacy treatment for a long time. So she was taking natalizumab for a long time, and then subsequently plan was to give rituximab. You see here, you see this lesion. You see it is only involving a few segments. You see this multiple lesions here. So this is the typical, they are ovoid perpendicular to the ventricle. This is the typical feature of multiple sclerosis. Second scenario, a middle-aged man presented with unsteadiness and slurred speech, treated with steroids and improved. He had recurrence of symptoms with significant dysarthria, dysphagia, and unsteadiness. MOG was positive. Since he had relapsed, he had been given rituximab. He is better after rituximab. So MOG should be treated with immunosuppression ideally after the first relapse. Till then, it is advisable to maintain them only on steroids for 6 months, low dose, full dose for 1 month, slow taper, and then 15 milligram per day. You see, initially this was the only lesion. Subsequently, you see, he had a large lesion in the brainstem. He had significant dysarthria, dysphagia. Okay, now this is a lady in her mid-30s, presented with severe headache, was diagnosed to have chronic subdural hematoma. Operated, doing well, no history of trauma. 3 months later, she presented with optic neuritis with afferent pupillary defect. So MRI showed, you see here, this is the dural enhancement. So this was the clue. Otherwise, we would have just treated blindly as optic neuritis. So she was positive for IgG4. So IgG4 diseases can mimic a demyelinating disorder. So she has been treated with 4 months of steroids. She is doing well now. Now this you see the long segment involvement. This is a typical feature of neuromyelitis optica. These patients will be very sick at admission, and such patients it is better to avoid lumbar puncture. So this is regarding the case 3. So finally, what are the take-home points? Try to fit acute demyelinating disease of central nervous system into either multiple sclerosis, neuromyelitis optica, or MOG. Sorry, the third one should be MOG. With a combination of clinical features, MRI, blood investigation, OCT, it is fairly easy to differentiate the 3. Treatment strategies, prognosis, and duration of treatment are very different amongst the 3 diseases. If one cannot fit into the above 3, look for other diseases like sarcoid, IgG4, vasculitis, etc. One has to be very specific in diagnosis and treatment, follow the guidelines, and not to institute blind symptomatic and immunosuppressive treatment. Thank you.
Thank you, Dr. Prachit sir. It was a nice overall discussion about the neurological problems. We will have the questions at the end of the second session also. So now we will go for the second session.
Dr. V. Rajesh Babu needs no introduction. He is one of the most charismatic persons in our neuro fraternity. He is right now a senior neurosurgery consultant at Ganga Hospital and also the president of IMA Association Coimbatore. He did his MBBS in 1987, MS General Surgery in 1997, and Neurosurgery in September 2001. I welcome Dr. Rajesh Babu once again to enlighten us about recent concepts about brain death.
Good evening, everyone. My topic is the brain death certification and organ donation. Why this topic is in this forum, in the Neurosciences Forum? The 2nd August is celebrated as the National Organ Donation Day, and 13th August is celebrated as the World Organ Donation Day. That's why this month being Organ Donation Day month, we are planning to have this in this forum, and our neuro doctors and IMA doctors should know about the organ donation. So Tamil Nadu, the state organ donation day, they have a separate thing, 23 September 2023. And the Tamil Nadu is the state where the organ donation activities are excellent. The practice of observing the September 23 as the organ donation day began in Tamil Nadu after the tragic death of the 15-year-old H.P. Itendran in 2008. His parents, Dr. Ashokan and Dr. Puspanjali, decided to donate his organs. This incident sparkled the movement like a resurgence in the organ donation across the state. To recognize and promote such donations, CM Karunanidhi declared September 23 as the Organ Donation Day. So that's why the 23 September 2023 is taken as the State Organ Donation Day. Here I put my mother immediately after her death on 3/3/2022. We have donated the eye and the skin. Immediately we have donated both. See, organ donation, why it is so important? Which is the regular common organ donations you heard about, known about it. See, in our histories, the Lord Ganesha had the organ donation, the head. Then the Kannapar story, all of you must be knowing, and there also the eye donation is happening like that, trying to do it, and then finally, you see, Lord Shiva helps him. And another one is our Karnan. In the Karnan, you must be knowing in the Karnan story. In the Karnan story, in that, in the history of the Karnan, Krishna comes and asks asks for all the donations, and the Karnan gives all the donations to what he has done in his life. That is what he has done. like that the kernel donates there itself the donation has started like that. So what is a brain death? Brain death is the brainstem dysfunction. It is not about the parietal lobe, frontal lobe, temporal lobe, and occipital lobe and cerebellum dysfunction. It is only the primary brainstem lesion. That only, if it is getting affected, then only we call it as the brain death or brainstem death. So in the brainstem death, the organs, the midbrain, pons, and medulla oblongata. Midbrain, pons, and medulla oblongata, when it is dysfunctioning, here you see midbrain, pons, and medulla oblongata. If they are not functioning, we call it as the brainstem. So what are the functions of the brainstem? Awakening, blood pressure, the deglutition, eating and the breathing, and then pulse. All these things are the functions of the brain. So total and irreversible loss of functions of the cerebral hemispheres and the brainstem is called as the brain death. Brain death is a condition where the brainstem and midbrain, pons, and medulla oblongata of dysfunctional status. In this condition, heart will be beating, blood will be running all around the body, and urine will be excreting, but the brain will not be functioning. So it is an irreversible unconsciousness with complete loss of the brainstem function. So what are the causes of the brain death? Are the tumor, trauma, intracerebral hemorrhages, and ischemia. So to protect from the brain death is we need to wear the helmet while riding a bike also. So what are all the causes of the brain death? See, this is the normal brain, usually seen in the CT scan, and here the cerebral anaxia, which is seen. And this is once again normal, and this is abnormal. There is a white spots are the cerebral hemorrhages. And this is the normal brain, and this one is the subarachnoid hemorrhage. See the bleeding inside the cell site. And this is the normal brain, and this is showing after the trauma, there is a fracture, and then the contusions, all these things are there. And then the normal brain, and this is the meningitis, the diffuse cerebral edema, which is seen here. So what are the cause of the brain death? Are the head injury, brain injury, spine injury, and the polytrauma. That only produces the. So all are injuries, and injuries can be prevented. So the brain will be like a stone, like it is like this. So once a person is diagnosed as a brain death, the intensivist one who is treating intensivist decide that it is a brain death stage. Then we follow the instructions given by the Transtan, the Transplant Authority of Tamil Nadu, or ROTO, Regional Organ and Tissue Transplant Organization, or the SOTO, the State Organ and Tissue Transplant Organization. How to find out the brain death, the coma, unresponsiveness to the deep painful stimuli. The Transplantation of the Human Organ Act, the THO Act 1994 was created, and subsequently it was dated on 3/3/2008 only. The bill was passed in the Parliament, and the following recommendations are modified for the brain death on 25/2023 at the Transtan. So the prerequisite for diagnosis of the brain death are the evidence of irreversible brain injury of unknown etiology, irreversible loss of consciousness and cessation of the spontaneous breathing. We should exclude the alcohol intoxication, dependent drugs, and narcotics, and muscle relaxants, primary hypothermia, hypovolemic shock, and metabolic or endocrine disorders. How to find out the brain death are these are all the tests that can be done. Absent on the bedside or the brainstem, absence of the brainstem reflexes, pupils fixed and dilated, corneal reflex, cough reflex, gag reflex are absent, Dalsey movement absent, bilateral caloric testing negative, cold caloric test, no spontaneous respiration, apneic test positive test, flaccid extremities, deep tendon reflex are absent, pain response to pressure over the supraorbital ridge is negative. So to confirm the brain death, the brain arteriogram is the confirmatory test nowadays. Even the EEG, people are not following it up now in certifying. So what are all the ancillary tests? Is the CT cerebral angiogram or DSA of the cerebral circulation, MRI cerebral angiography. The CT cerebral angiography is the ancillary test of choice and is recommended. The 4-point CTA criteria has been shown to have 100% specificity, 0% false positive rate, and 85% sensitivity. That is 15% false negative rate. The 4 vessels looked in are 4-point scoring system are right cortical branch of middle cerebral artery, M4 segment, left cortical branch of the middle cerebral artery, M4 segment, right internal cerebral vein, left internal cerebral vein. For each vessel that shows lack of contrast flow, 1 point is given. If all the 4 vessels show no contrast, then it is the score of 4/4. That implies patient is brain dead. Score 3/4 or less is negative for brain death. Sequence of clinical or ancillary test is done minimum of 6 hours after the first set of performable components of the clinical brain death. We need to do it. If ancillary test demonstrates angiographic findings supporting to diagnose of the brain death, second set of clinically performable tests are to be done immediately after the positive ancillary test. The clinical findings are consistent with the diagnosis of brain death. The patient is declared dead. So, declaration of the brain death adult. All the above findings should be present on 2 occasions 6 hours apart. First, we have to do this all the bedside test and ancillary test confirmation, and then we have to repeat it after 6 hours. Then only, if both the times it's confirmed, then only we can certify as brain death. Declaration of brain death in children. All the above findings present on 2 occasions. The children up to 30 days, that is the neonates, it is 24 hours between the test, not the 6 hours. And for the children from 31 days to 18 years, as up to adult stage is 12 hours. So 6 hours for the adults, 12 hours for the children, and 24 hours for the neonate. If ancillary test is negative, when we are performing, the bedside tests are okay. If ancillary test is negative, time period to repeat the test is repeat after 24 hours. If strong clinical grounds for the brainstem persist. How to confirm brain death? The patient should not be with the poison intake, danger poison. So, how to finalize the brain death? Certifying doctors, team of 4 doctors must certify the brain death. The RMP in charge of the hospital, the RMO, head of the institution, ARMO or duty RMO, no clearance required from the appropriate authority. Second is the neurologist or neurosurgeon. If not available, surgeon or physician and anesthetist or intensivist who are empaneled by the appropriate and registered medical practitioner nominated from the panel of names sent by the hospital and approved by the appropriate authority. Physician, surgeon or intensivist. RMP treating the deceased person, no clearance is required from the appropriate authority. Brain death certifiers, specialties, they have to get the empanelment from the Transtan. Neurophysician, neurosurgeon, anesthesiologist, intensivist, general physician, general surgeon, pediatrician, respiratory physician, and cardiologist. Why the organ donation is very important? This more than 5 lakh Indians are dying every year just because of the failure of their major functioning organ system. So the kidney failure, cardiac failure, liver failure, and corneal blindness. You might have seen in the newspapers as the 7 people get the life. Who is the ideal organ donor? Brain dead patients, beating heart and urine excreting, but no breathing. That is the status of the brain dead person. This is the organ donation emblem. Organ donation is the removal of the tissues of the human body from a person who is declared as the brain dead. Age and organ donations. Up to 50 years, the kidney, heart and heart valves and lungs can be used. Up to 70 years, liver and trachea. Up to 85 years, skin. And up to 100 years, cornea. But this is not the rule that strictly need to be followed. But when the recipient doctors are ready to accept the organs, any age, any organ can be transported. The organ can be donated. That is the rule which our health ministry has passed. There is no limitation for the age and also the place of birth. That is from 16 February 2023 onwards. No age limit to receive organ above 65 years also can receive. Before there was a age bar of 65 years. No state limit. Any state register, any state receive from any state. and no money to be paid for the recipient registration. Registration, they can do it freely, no need to do any payment. So who can be a donor? Live donor and a deceased donor. The life is the related or unrelated is not at all possible. Live donor can be done. Deceased is the cardiac death, brain death. So who can donate? Live, above 18 years, one kidney when they are living, liver low, pancreas, lung low, and deceased, all organs and tissues. One organ donor can save more than 8 lives in his life by donating his well-functioning organ. Usually, I used to tell in all the meetings, what are all the organs that are present below the neck, you can donate. That's why. Above the neck, not possible. Below the neck, all the things, eye, kidney, liver, heart, lung, pancreas, small intestine, voice box, fan, the middle ear bones, skin and fascia, bone, cartilage, tendons, veins, arteries, nerves, fingers, and toes. All these things can be donated. So organs are tissue donations after the brain death. The major organs that can be donated for transplant are the heart, liver, lungs, kidney, pancreas, and the small intestine. Each tissue donation can benefit approximately 75 patients. Corneas, bone, veins, heart valves, and skin. The organs that can procure include heart, intestine, kidneys, and lung. So tissue or organ donation by a living person. When person is alive, blood, bone marrow, kidney, portion of the liver, portion of the lung, and portion of pancreas, which I already told. The main organs are the pancreas, kidney, and the liver. So, for the organ transplantation, in Tamil Nadu, we follow one thing called as a green corridor. Tamil Nadu is the first state to create a green corridors to quickly transport the donated organs to its destined hospitals. The formal name of green corridor was given in July 2014 when a hospital and police in Chennai coordinated to transport a heart from one hospital to another hospital in half the regular time. The system has been effectively used in cities like Mumbai, Gurgaon, Hyderabad, Bengaluru, Kolkata, and Indore. Green corridors are generally used for transporting the heart, which is to be done within 6 hours, liver up to 12 to 15 hours, which have the shortest preservation times. The means of transportation is often by road, but air ambulances are also employed when the organ require transportation to different cities or states. You might have seen in the TV that within 13 minutes, the organs are being transported from one place to another place. That's like that, it will be shown. And then, see, within 13 minutes, they are transporting from one place to another place. That is happened. And preservation and transplantation, the kidney up to within 48 hours, the pancreas 24 hours, liver is 12 hours, and heart is 6 hours. That's why we have to do it very fast. That's why the green corridor is very important. First time in India. What is the need for organ donation? 50,000 cornea transplantation only available, need is 2 lakh. 5,000 kidney transplantation need is 1,75,000. 1,000 liver transplant need is 50,000 and need 50,000 heart, need 20,000 lung per year. So Transplantation of the Human Organ Act 1994 is created to stop the donation racket. Amendments were made to the Transplantation of the Human Organ Act, which is passed in the Parliament in 2008. And there was a lot of modification from 1994 up to 1995, 2008 to 2011, and up to Transplantation of Human Organ and Tissue Foods 2014. So according to that, the Transplantation of the Human Organ Act, the Transplantation of Human Organ Act, spouse, son, daughter, father, mother, brother, sister, grandparents, grandchildren, uncles and aunts can donate their organs to their patient. Distant relatives and friends, very difficult. The unauthorized transplantations under Transplantation of Human Organ Act 2011, removal of the organ at risk transplantation without authority is punishable. 5 years jail and 10,000, which is now changed into 5 lakhs and 10 years imprisonment now. That's what happening. And the offences and penalties under Transplantation of the Human Organ Act, THO Act, And in submission of false documents, imprisonment up to 10 years and a fine up to 20 lakhs and 1 year, 1 crore. The commercial dealing in organ, imprisonment 2 to 7 years. Fine, which was 10,000 to 20,000, now turned into 20 lakhs to 1 crore. And penalties for doctors. First offense, name removed from the state medical registry for 3 years. They cannot practice. Subsequent offense, name removed permanently from the registers. Then regarding the eye donation, everyone may be knowing more about it. In eye donation, we from IMA are thinking about creating an IMA eye bank because the number of eye which was retrieved are very, very less. We are in want and we are in scarcity. So that's why we are thinking in terms of eye retrieval centers in all the IMA. We are having a workshop on 29 August 2025 at Coimbatore Medical College, Coimbatore, from morning 9 a.m. to evening 4 p.m. I invite all of you to please register and come and attend the program, which will be very useful. And you also can be a part of the eye bank retrieval centers. Can you imagine your life in the darkness? Eyes are precious. 1.8 million cornea blind in India, out of which 1 million are children. So do not burn, do not bury, donate eyes. Donate eyes, give sight, pledge today. Then regarding the skin donation, I want to tell one among the two skin banks in South India is at Ganga Hospital, Skin for Life, Skin Bank for Burn Victims. Skin banking is a facility where skin is collected from the eligible deceased donor, which is then processed, preserved, and distributed as per the international protocols. The burns accidents in our every day we face in the domestic accident, industrial accident, road accident, cracker, the skin is lost. The skin is the largest organ in the body, which is measuring about 20 square feet and weighing 3.5 kilograms. It plays a critical role as the body's protective cover, regulating the blood body temperature and protecting from our bodies from the damage and infection. Cross section of the skin and the level, this is the 3 degrees of burns are there. Why a skin bank? Here you see the skin is lost most of the parts, both the lower limbs and also in the chest. So where from you will take skin to cover? That's why skin bank skin is used. Cause of death in major burns are the dead skin causes infection. If we remove dead skin, then again the raw area is open for infection. In a major burn, there is not enough skin to replace from the patient. So imagine this is the area where it is burns is affected. Where from you will take? If you take the skin from this area, that also will be a raw area. So that's why the skin from the skin bank will be of helpful. The skin from the beak is used to cover the raw area, remove the dead burned skin early. The skin from the bank protects the individual from the every 2 to 3 weeks. In that period, the patient picks up general conditions slowly in incremental stages. We replace it with its own skin. So anyone beyond the age of 17 years who does not suffer from HIV, hepatitis, or who die from septic disorders, taken within 6 hours of death, similar to eye donation. After death, the sign is brought from the relatives, collection of blood for investigation. Skin is harvested within 6 hours of demise, very thin layer. Skin harvested areas are not obviously so, no bleeding. Skin harvesting is done with the dermatome like this. After harvesting, dressing is applied like this. And the skin is put in the glycerol and is transported. Trimming of the skin with the samples. And then glycerol is added to the skin sample. Skin is stored at 5 degrees Celsius. Meshed skin can be used. Burn injury, skin transplantation. In home, how skin is taken? Skin transplantation, in the way they fully put the protective areas and then they take the skin for the skin transplantation. In the home, how they take the skin? With the dermatome they used to take. The areas are the limbs they are taken. In the back they are taken. That's what happened. So they will cover the body like this. So in home, how skin is taken? Skin is covered. And the skin regarding skin donation, I want to tell. When my mother's sister husband died on 21/3/2002 due to old age at home, Immediately I have arranged for an eye donation and skin donation. That is the fifth such skin and eye donation I am arranging in 2 years. Who can receive? Anyone can receive blood group, tissue typing, or no bar. The process of preservation removes the antigenicity and so it can be used for anyone. When you donate skin, you give life. This is a skin donor card. This is the contact number of the Ganga Hospital for the skin donation. Those in died willing to donate the skin, they can note this number. How to prevent the brain death, avoid head injuries, protect our brain like a helmet protects like a mother protecting her child in the uterus, and seat belt. Not too much of people going. Take care of your head. Not everyone gets a replacement like it. Oh my God. And this is we used to create awareness meeting for all the people. So don't take your organs to heaven for heaven knows they are needed here. Live pass it on. Previously for the organ donation, the one thing called as the forum called as the MOGAD Foundation, Multi-Organ Harvesting Aid Network was the thing which they were doing. Where we stand in comparison to Western countries, only 0.01% of the Indians pledged to donate their organs with respect to around 70 to 80% in Europe and USA. Surprisingly, when it comes to donation, in India, women are the one donating more than men. The ratio is 20 is to 80. That's what happening. And where in India is standing? India has performed the second largest number of transplants in the world in 2019. India lags far behind in the Western nations. In the Spain, you see all the foreign nations are about the 35.1 per million population. India, it is only 0.65 million per population only is there. So organ donation in India is regulated by the Transplantation of the Human Organ Act 1994. The law allows both the deceased and the living donors to donate their organs. It also identifies brain death as a form of death. National Organ and Tissue Transplant Organization (NATO) functions as the apex body for activities of relating to procurement, allotment, and distribution of organs in the country. In 2019, the Government of India implemented the National Organ Transplant Program with a budget of 149.5 crore for promoting deceased organ donation. The Tamil Nadu state, the death certification mandatory in 2008, becoming first state to do so. Between 2008 to 2019, after restarting the organ trade with new regulation, the state recorded 7,783 organ transplants. The Tamil Nadu stands first in the organ donation. Yes, already I've told in 2008, the Hitendra effect that only made this as the number one state in the organ donation. However, from 2008, organ donation dropped. In 2019, Tamil Nadu recorded only 128 donors. By 2019, the state had transplanted 7,783 organs from deceased donors. The Transtan is the Transplantation Authority of Tamil Nadu. A registered society was formed on 12/12/2014 under the Chief Ministership of Honorable Chief Minister of Tamil Nadu at that time, J. Jayalalitha. The general body consists of 21 members, including Honorable Minister for Health and Family Welfare, Honorable Minister of Finance, both. First is entire Transtan's entire functions are overseen by a executive committee of the people of the principal secretary to government of Tamil Nadu Health and Family Welfare. Transtan also function as the regional organ and tissue transplant organization and state organ tissue transplant organization by Government of India order and was registered as the society on 18 March 2015. Cadaver transplant program is one of the program run by Transplant and we will also coordinate and supervise the entire range of transplantation activities, including liver transplants, cadaver transplants, and tissue transplants. This is the address of the Transtan, which is situated at the multi-speciality hospital, Omandurar Government Estate, opposite to Hindu office, Anna State, Chennai. How to donate eye? These are all the phone numbers which, if you contact eye donation, in future we will be having a unique ID number for the phone. that if we call, immediately eye donation process can be done on the skin and also the bone bank also. So the procedure is the brain death. If happens, inform the transplant, 6 hours second declaration, family willing brain death, inform transplant, allocation process, MLC, police intimation, inquest and forensic clearance. Fees 25,000 per organ to the donor hospital, maximum is 75,000, restricted to be given by the recipient hospital. So this is the procedure which actually has come in the Times of India newspaper, which is showing, see, everything what I was telling till now is put up in a newspaper in the front page. That is what our thing. I don't know how many of you have seen. See the heart, lung, intestine, liver, pancreas, kidney, and all these things, and about the 8 lives, and how we should do the certification. Everything what I was explaining till now, it was given crisply in one page totally. That is the education to the public. So there are a lot of hospitals in the Tamil Nadu approved for kidney transplantation, heart transplantation, liver transplantation, and also the hand transplantation, skin banks, and all these things. The transplant, Tamil Nadu organ transplant units, there are 13 organ transplant units in the government of Tamil Nadu across the state. After the DMK came to power, 27 government medical colleges and hospitals were declared as non-transplant organ retrieval centers to increase the donation. The waiting list for organ transplant in Tamil Nadu is 2023 is 6,117 patients waiting for kidney, 448 for liver, 72 for heart, and 60 for the lungs, and 24 for heart and lung. See, if you go to the transplant website, you can see this. There are 13 organ transplant units in government hospitals. The total waiting list, everything is shown in one page they used to give. And this is about the organ transplantation which has been done so far. That's what happening. And everything is given clear cut. So organ transplantation info. Chief Minister's Comprehensive Health Scheme. Tamil Nadu is the first state to provide financial assistance up to 22 lakhs for any organ transplant, which is being done. And 588 end-stage organ transplant patients have benefited from Chief Minister's Comprehensive Health Scheme in Tamil Nadu. There are some new proposals coming. In the Coimbatore, skin bank may soon come up in the Coimbatore Medical College Hospital. That's what a new message has been, which appeared in the newspapers last month. So organ donation, they are maintaining registry. We give awareness to the people about the organ donation by pledging the organs. The donor card, which was the card which they were given, see the Tamil Nadu government emblem is there. What are all the organs they are donating, everything. The cadaver transplant program, phone number and all those things are given. Previously, when we register in the Transtan, we will be getting a card like this. And now, if you go to the website, which is called as the https transtantn.government.in, immediately follow the steps and then you will be able to download the card. This is how Transtan, and then next is the all the steps we need to follow it up and then get the card. This is the card which I have downloaded from the website, which is showing all the organs. Okay. And this is the latest card. This is the old card and this is latest card. In this, they have put a national emblem like this, Ashoka Chakra, Ministry of Health and Family Welfare, and the Ashoka Chakra is there. All these things are there. So this is the QR code, everything, organs donation, issues, everything is mentioned there, which I have downloaded on 27 February 2025. So now latest, there are some problems happening. Scam you might have seen in the papers in Euro, Trichy, Namakkal area. Actually, now they have banned 2 hospitals, one in Trichy and another one in the Paramalur area, where they got money and the transplantation is being done for 5 people. Out of which one lady got caught, but 4 ladies, they were not able to catch them. And there is a new type of an organ donation is happening. That is in Coimbatore, they have done it in Gem Hospital and Ramakrishna Hospital. Liver from one hospital is given to another hospital patient. So regarding the organ donation, in September 2023, a significant decision made from the Chief Minister said that funeral of the deceased whose organs are harvested for donation will henceforth be held with the state orders. Since the announcement in the December 2023, the number of organ donations have increased, and organ donation pledges were more 88,000 since September 2023. And this is how they used to do. In Pudukkottai, one of the medical colleges, this is what nowadays people are doing it. So in 2025, on 2nd August, Tamil Nadu bagged the National Award for Organ Donation in 2024. The total 268 donations from the brain dead persons, more than half from the government institutions happened since 2023 September, total 479 transplantations. In 2024, up till now is 268. And for this, Tamil Nadu first place, the best brainstem death certifying team for Madras Medical College was given. And our HOD, Dr. Raghavendra, is collecting the certificate from the government. That is what the status of our organ donation nowadays in our Tamil Nadu. So people to be honored are, because it is a very big work, grief counselors, top performing hospitals, police personnel who facilitate this swift transport of organs, ambulance driver, doctors, voluntary organizations, and organ donor clubs. And educating the people like this by showing from the movies, the movie actors, then only people will be able to know more about this. Like this, we can propagate the messages. Thank you. So it is time for giving a thanks. First of all, I thank our neurophysician, sir, even in his busy schedule, he has given a nice talk. Dr. Prachit, sir, for giving the time to present this very difficult topic and enlightening all the people, the neuro doctors, the PG students, and also the IMA members. And every month we are doing the program continuously without any gaps. We see to it is happening on Tuesdays because Monday is being a busy day. People will not be able to have time to attend. That's why we fixed as Tuesday. And also we are not fixing on Wednesday because there are some CME being conducted by some of the forums. And also the weekends, Thursday, Friday, people have the conferences. So to avoid a clash with the thing, we are having the program mostly on these Tuesdays. So I thank all the participants who has done. Actually, we have got around 80 participants have come at one time. And it was very nice to have the forum. I thank you one and all, and also especially the Naveen Kumar and also the East West Pharma who are all actively helping us in doing the program. Thank you one and all. Thank you, Prajit sir, exclusively. Thank you, sir.
Thank you, doctor. Thank you, sir.